Hi everyone, what's going on? My name is Dr. Susan Kafle, and today I'll be discussing about the red nucleus. Before we move on to the midbrain syndromes, this is a very important structure that we should learn to understand the concepts behind the syndromes. Alright, so let's begin without a delay. So in today's video, we'll learn about the location of the red nucleus. What are the inputs to the red nucleus? What are the outputs from the red nucleus? What is its function, and the diseases of the red nucleus that are clinically important. So this is the structure of a midbrain. The midbrain, this is at the level of the superior colliculus. All right. So here we have a cavity in the center, so that is the cavity where the CSF is flowing. That is called the cerebral aqueduct, and around the cerebral aqueduct we have the periaqueductal gray. Now this midbrain can be divided into three regions. The posterior most region is the tectum. So just for reference, this is the posterior side and this is the anterior side of the midbrain. The posterior most region is the tectum. Then we have tegmentum at the middle, and the most anterior part is the cross cerebri. As I said, this is at the level of the superior colliculus, so we have superior colliculi at the back. On the lateral side we have medial lemnisci. In the front we have the substantia nigra, and here towards the medial side we have the red nucleus. And in the most anterior portion we have the descending fibers of the corticospinal and the corticobulbar tracts. Remember, the corticospinal and corticobulbar tracts, they are originating in the cerebral cortex, descending downwards through the midbrain. So these fibers are lying at the cross cerebri of the midbrain, and then they descend down at the level of the caudal medulla. They decussate to the other side and then descend in the spinal cord. We also have the third cranial nerve nucleus, that is the motor nucleus. I've just highlighted the motor nucleus here. I'll be dedicating a different video for the third cranial nerve after this, maybe. So the motor nucleus is relevant while we are discussing the syndrome, so I've drawn it here. It is present in the medial part of the midbrain, and since the fibers that are the third cranial nerves through the anterior portion of the midbrain. So our red nucleus, it is present in the midbrain tegmentum at the level of the superior colliculus. Now why am I saying superior colliculus? Because at the level of the inferior colliculus, the midbrain section looks something like this. So we don't have the red nucleus here, rather we have decussating fibers from the superior cerebellar peduncle, and the fourth cranial nerve is originating at the level of the inferior colliculus, not the superior colliculus. At the level of superior colliculus we have the third cranial nerve, whereas at the level of inferior colliculus we have the fourth cranial nerve nucleus. Now in the last slide I said that the fibers of the superior cerebellar peduncle, they decussate at the level of the inferior colliculus in the midbrain. So what actually does this mean? So we are seeing the midbrain or the brainstem from the back. This is the back view of the brainstem. So this one here is the superior cerebellar peduncle. From here, from the different nuclei, mostly the dentate nuclei, the fibers originate and they cross to the other side. All right, and the fibers cross to the other side and reach the red nucleus. If we are seeing from the side, the fibers are originating from the cerebellum and they are ascending upwards into the midbrain. The region where they go to is the red nucleus, and from there some of the fibers synapse there, whereas some fibers they ascend directly to the thalamus. So two different types of fibers are present. The one that comes from the cerebellum and synapses in the red nucleus is called the dentatorubral. Rubral means red, right? So dentatorubral fibers, the ones that pass through the red nucleus to the thalamus are called the dentatothalamic fibers. These two types of fibers are passing through the red nucleus. Now let's talk about the major inputs to the red nucleus. So as I've listed here, the two clinically important inputs to the red nucleus are one from the motor cortex, which we call the corticorubral fibers. They come from the motor cortex and synapse in the parvocellular red nucleus. The red nucleus basically has two components. One is the magnocellular and the parvocellular. So the inputs, they are coming to the parvocellular nucleus. So one is the corticorubral fibers and the other is the dentatothalamic fibers. So they are also coming to the parvocellular red nucleus from the cerebellum. So as you can see here, these are the first types of fibers originating in the motor cortex, descending down to the red nucleus, the corticorubral fibers. And the other one we have the fibers that are originating in the cerebellum and ascending upwards. These are the dentatothalamic fibers. As I said in my previous slide of this video, the dentatothalamic fibers pass through the red nucleus without synapsing on their way to the thalamus, like you can see here. These fibers are going to the thalamus and they are synapsing there. Now what are the outputs from the red nucleus? There are two main outputs that are clinically relevant now. One is the rubrospinal tract, which originates from the magnocellular red nucleus, and the other is the rubro-olivary tract, which originates from the parvocellular red nucleus. So we have the red nucleus here, and we have a nucleus in the cerebellum over here. Now the first tract is this rubrospinal tract, which immediately crosses after origin to the other side. So it is crossing here, right? So after crossing in the midbrain itself, it descends downwards and supplies the flexors of the upper extremities, not the lower extremities. It actually assists the main flexors or the main motor fibers from the corticospinal tract that are coming from here and descending to the other side. The rubro-olivary tract, it originates from the red nucleus, descends downward ipsilaterally into the inferior olivary nucleus in the medulla, and from medulla we have the second order neurons that those neurons form the climbing fibers. They cross immediately and then reach the cerebellum. Now I know the thing that I just talked about is pretty complex to understand, so let's try to understand this with an example. For example, you decide to touch your nose with your left hand. Now how does this happen, this movement occur? So first, the primary motor cortex over here sends a signal, move my arm to touch my nose to the other center. So basically the corticospinal fibers originating from the primary motor cortex descend downwards, deposit in the medulla, and go to the other side and try to move the left upper arm. Whereas at the same time, the primary motor cortex also sends the signal to the red nucleus via the corticorubral fibers to fine-tune the movement, At the same time, the red nucleus also receives the proprioceptive feedback from the cerebellum via the dentatothalamic fibers. As I said, there are two inputs to the red nucleus. One is the corticorubral fibers and the other is the dentatothalamic fibers. So the dentatothalamic fibers tell the red nucleus where the hand currently is, in what direction it should move in order to touch the nose. And after that, after receiving these two feedbacks, the red nucleus gives rise to red nucleus via the rubrospinal tract, descends downwards, accompanies the corticospinal tract. Remember, these two, rubrospinal and the corticospinal tracts, they are located very close to each other in the spinal cord. So they are running together, and the rubrospinal tract assists the corticospinal tract to make that movement. The corticospinal tract is just trying to make a very gross movement, but the rubrospinal tract, having received the feedback from the cerebellum, it tries to fine-tune the movement. and after it does that, the rubro-olivary fibers from the red nucleus, they provide ipsilateral input to the inferior olivary nucleus, which via the climbing fibers reaches the cerebellum and tells that this movement has been made, and the cerebellum senses that movement, and then it again sends the corrective input or the feedback to the thalamus uh, via these fibers. The fibers are the dendrothalamic fibers. As you can see, the dendrothalamic fibers arising from the cerebellum and ascending through the red nucleus. So this is how the movement is occurring. The cross movement is occurring with the help of the corticospinal tract. The fine tuning is occurring through the rubrospinal tract. So what are the main functions of the red nucleus? Basically, it facilitates the movements of the upper limbs via the rubrospinal tract and also provide the feedback to the cerebellum via the rubro-olivary tracts. Now, what happens when the red nucleus is damaged? Since the red nucleus is receiving the input from the cerebellum to fine-tune the movement, this fine-tuning will be lost. So that will lead to contralateral tremor. And then it also is receiving an input from the cerebellum regarding the proprioceptive impulses. So there will be contralateral ataxia and incoordination. And then the main function that the rubrospinal tract carries is the fine tuning of the movement and facilitating the flexion of the upper extremities. So there will be a loss of flexor facilitation in the upper limb. And now some clinical correlation of the things that we just learned. In some of the brain syndromes, there are 5 different types that I'll be discussing in the upcoming videos. Especially in the type Benedict syndrome and the Claude syndrome, we have the involvement of red nucleus. So there will be contralateral tremor, ataxia, and there will be involuntary movements like athetosis, chorea, etc. And when learning the GCS, we have 2 different postures in the motor component of the GCS, right? One is the decorticate posturing and the other is the decerebrate posturing. So what does this have to do with the red nucleus? So see, the red nucleus via the rubrospinal tract, it is controlling the flexor tone of the upper extremities. So say that we have a lesion above the red nucleus that spares the red nucleus. If the red nucleus is spared, it can, although the corticospinal tracts are damaged, the output from the red nucleus is intact. So if this output is intact, then even though our bodies have the natural tendency to extend, but the extension does not happen in the upper extremities because the red nucleus via the rubrospinal tract flexes the upper extremities, whereas the lower extremities are extended. But in decerebrate posturing, the lesion is below the level of the red nucleus, so these fibers are cut. Now what we have is the body has natural tendency to extend all its extremities. So the limbs will be extended as well as the upper extremities will be extended because we have lost the little bit of flexor tone that we were getting from the red nucleus by the rubrospinal tract. So this is important to understand. All right. So that would be it for this video, guys. So in the next video, I'll discuss about some other clinically relevant things that we need to discuss before moving into the midbrain syndromes. Stay tuned, subscribe to this channel. I hope that you have a great day. Thank you.